Well, good morning to all of you. Good morning to those that are joining us through Salud Derecho web streamed, to our community of practice working on right to health. And it's going to be translated into Spanish, but we will going to be speaking in English. And there is also someone that is going to be blogging on the World Bank about right to health. So we have heard something about, there is a right to health, but we really need to think a lot about what does that mean, and it means different things for different people. So we thought to have this interesting discussion, and I have the privilege to have this panel here of very different professionals with different backgrounds that are going to tell us about what do they understand about the right to health. First, I have on my left Dr. Rodrigo Uprimny, and he's the director of the Center of Law, Justice, and Society in Colombia. He's also director of the Masters of Law program at the National University. He's a former assistant judge of the Constitutional Court, and he also is an expert for the Inter-American Court of Human Rights. Next to him is Dr. Harald Schmidt. He's assistant professor of medical ethics and health policy and a research associate at the Center for Health Incentives and Behavioral Economics at the University of Pennsylvania. He also was assistant director of the UK NAFL's Council on Bioethics. Next to him is Dr. Marc Roberts. Professor Roberts is Emeritus Professor of Political Economy and Health Policy at Harvard School of Public Health. Professor Roberts is also a professor at the Kennedy School, and he has more than 30 years advising countries on health reform and health systems. And at the end of the table is Dr. Albert Mulley. He's the director of the Dartmouth Center for Health Care Delivery Science. He's the founding chief of the General Medicine Division and serves as director of the Medical Practice Evaluation Center at the Mass General Hospital in Boston. And he was also associate professor of health policy at Harvard Medical School. So we are going to start with something that is quite real for many of the countries that we are working on here at the World Bank. So as you know, one of the main reasons we are working in the health system here at the bank, and one of the goals that President Kim would like for the countries that work with us, is to help them, to support them to move towards universal health coverage in an equitable and also efficient way. And that means also many things when you think of a country that also enshrines the right to health in their constitution. So we are going to do here a conversation, and we are going to hear the different perspectives of the different professions. So we can hear what does it mean, the right to health from the judicial side, or from the bioethics point of view, or from the economics and health systems point of view, or from the delivery of services point of view. So my first question will be to ask Dr. Rodrigo Uprimny to tell us what does it mean to have a right to health. And before that, I want to make it even more clear when we talk about the right to health by reading what you have on the screen in the back. And this comes from a country that's a client of ours that has in the Constitution the following wording. And as you can see, it says, our country, Africa, in the Constitution says, in the Article 23, every person has the right to the highest attainable standard of health, which includes the right to health care services, including reproductive health care. It continues in Article 38 saying, it is a fundamental duty of the state and every state organ to observe, respect, protect, promote, and fulfill these rights, and the state shall take legislative, policy, and other measures, including the setting of standards to achieve the progressive realization of the rights guaranteed under Article 23. So this is a resource-constrained country, and we'll give more information about the country, but I can tell you that this is a country that is starting to get decentralized, and the health services are going to be now in the hands of the local authorities. This is a country where the quality of care is affected by strong inequalities. It has a per capita income of only $150. People pay out of pocket for services, and we're going to more details after we hear from them. What does it mean for you, Dr. Uprimny, to have the right to health in the Constitution?
Thank you, Maria-Luisa. I want to begin with a caveat. I think there is not really a consensus about what are the legal, ethical, and political consequences of incorporating something like a right to health in the Constitution. There are disagreement between scholars and international institutions about what are these consequences, and also there are discussion about what does it really mean to have a constitutionally right-based approach to public policy and to health policy in particular. Having said that, nevertheless, I think that the fact that you incorporate something like a right to health in the Constitution has at least four very important consequences. First, in relation to the establishment of a state duty. Second, about the process of public policy in the health sector. Second, about the goals of this public policy in the health sector. And finally, about the issue of accountability. And let me try to explain very shortly these 4 points. About the existence of a state duty. When you incorporate a right to health in the Constitution, and as in this case of the AFRIA Constitution, then you establish that the state has a duty to respect, to protect, and to fulfill the right of health. The notion of the right to respect doesn't incorporate really very radical differences with the kind of traditional constitution like the one of the United States. It's a negative right or a negative obligation in the sense that the state should not do things that affects negatively the right of health of citizens. But the notion, when you incorporate the right to protect and to fulfill, then you establish positive obligation of the state. The state is compelled to take actions in order to allow citizens to enjoy the highest attainable standard of health. And these have very strong consequences because it allows the state to do things that otherwise would be controversial if the right to health is not, was not in the Constitution, and even to make things. It's obliged to make things that the state wouldn't have the obligation to do had the right to health not been in the Constitution. And that's very important. I'm sure that if the United States Constitution has had the right to health, then all the discussion about the Obamacare health reform would be very, very different. Things that are constitutionally controversial in the United States wouldn't be at all in other countries in which the right to health is in the Constitution because there is the obligation of the state to fulfill the right to the health of citizens. The second important point is about the process of public policy in the health system. If you recognize a right to health, then you establish that the needs of the citizens are no longer just needs, they become rights. They become claims that are, in a sense, enforceable even by courts. And second, that the action that the state takes to satisfy these needs are no longer a political decision or political question that the state can or cannot do, but these are obligations. It's not anymore some kind of humanitarian assistance, but an obligation of the state. And this has implications in the way the state has to develop a policy in relation to health system. In international law, we know this obligation as the cross-cutting human rights principles of all public policy that is framed in a human rights based discourse. And these are at least four. I'm only to mention it, and afterwards, in the next discussion, I can develop it a little more. These are the idea of participation. As citizens are now holders, then they should be allowed to participate in the main decisions that are taken in relation to the health system. Second, the issue on non-discrimination. That means that the public policy should be developed in an egalitarian way, and the state has the obligation to remove, for instance, gender discrimination, religious discrimination, even income discrimination to access health services. Third, there is the notion of transparency, that is that the decision might be done in a transparent way. And if you combine the issue of non-discrimination and transparency, this implies a duty of the state to have data, clear data, and disaggregated data, for instance, according to a gender perspective, to see what is the impact in women or men of different health policies. And finally, the issue of accountability, in which I will return a little later on. The third consequence is about the goal of health policy. The goal of health policy, it might sound very, that it doesn't have really a meaning, but I think it has it. The goal of health policy is to satisfy a right. It's not to make health policy because it's good for development. Of course, it is good for developing, much more better. But the goal of health policy is to satisfy the content of the right of citizens. Then it means that even if some provision of healthcare facilities are not cost-effective in terms of development, you might nevertheless do it because the citizens are entitled to that. So, of course, you have to make some kind of articulation between development decision, growth decision, and right decision. But that means that this means that the object is to satisfy the rights, not to make decisions that are good for development. And that makes tensions, but also complementarities between the notion of rights and the notion of development. And finally, there is the issue of accountability. If you enshrine in a constitution the notion that citizens has a duty, a right to health, this means that authorities have a duty to take some decision and to refrain from those decisions, and the citizen must have ways to make accountable the authorities of these duties, even by judicial means. And this means that in certain countries, it's not in all countries, but in certain countries, like in South Africa, like in Colombia, and some countries in Africa, this means that these rights become justiciable. What does it mean? That citizens can go to courts to make claims about these rights when they are denied, for instance, for treatments that you think are at the core of the satisfaction of these rights. So I think that the incorporation of a right to health in the Constitution is meaningful. It's not a meaningless decision. It has legal consequences. There is debate, as I said at the beginning, but they have legal consequences, and they have consequences in the way resources are allocated. So I think it's a very important decision in any country.
Thank you very much, and I think it was very enlightening. And now that I'm going to be being the Minister of Health of Africa, and I'm starting to get thinking, wow, this is more serious than I thought, and it has. We'll go back into that. It has a lot of consequences, as you explained, in terms of the process of public policy. So now that I know that the rights of my citizens are justiciable, that's the way to say it. Then I would like to ask Professor Marc Roberts, what does it mean from your perspective?
Well, First of all, I agree with my colleague's characterization of what the key implications are. He said that the claims were justiciable, that people had a right to make claims under the Constitution, and so on. I want to offer two arguments that I think are likely to be extremely controversial, and many of you will disagree with. Argument number one, this is a dangerous idea. And argument number two, it's an unclear idea. It is both unclear and dangerous, and it's in part dangerous because it's unclear. Why do I mean it's unclear? Could we go back to the previous slide, Maria-Luisa? So if you look at this claim, if we talk about the highest possible level of health, what exactly does that mean in a resource-constrained environment? Does it mean that every citizen who would like to have a cancer medication that costs $150,000 per case has a right to go to court and sue for that? Does it mean that a citizen who would like to have a cardiac transplant for cardiomyopathy and it's not available in this country can go and ask the government for $150,000 to go to Egypt or Turkey or South Africa for their transplant? So the point is, once we understand that resource constraints mean not everybody is going to get everything in the short run, and I think that claim is difficult to dispute, then the question is, how do we decide who's going to get what in the short run? And then the question is, does the presence of this claim in the Constitution facilitate that process in a constructive way? So having argued that it's unclear, I now want to go to argue that it's unhelpful, because it provides no guidance for how to think about the question of priority setting. Given that we can't do everything for everybody, how should we actually proceed? So there are various possible ways you could think about it. You could say, let's give priority to the people who over their lifetime have the worst health status. This is the view that John Rawls argued for in his book, Justice is Fairness. Bring up the bottom. The difficulty with bring up the bottom is that some people at the bottom are extremely difficult to help. This is a problem philosophers call resource hijacking. Some people would require very, very expensive care. Someone is quadriplegic. They might require hundreds of thousands of dollars of care per year. And, of course, if resources aren't free, if we spend hundreds of thousands of dollars on a few dozen cases and we take $2 million out of the budget, it's got to come from somewhere. And even if you say, well, then the health budget should go up, well, what happens to primary education, or what happens to infrastructure, or whatever? So my view about this is that governments need help in thinking intelligently about the problem, and if we're going to respect the process rights of citizens, if we're going to respect the right to transparency and the right to accountability, then in a resource-constrained situation, the only way a government can satisfy that accountability obligation is to announce explicit criteria for the resource allocation decisions, so that it can be held accountable for where it spends money and where it doesn't. And as I've said, this principle doesn't tell you how to do it. Also, I'm sure not as conversant with the literature in Latin America as my colleague, but the studies that I've seen suggest, and certainly one's experience suggests, that justiciability is a right that is extremely resource dependent. Who has the resources to bring a legal case? Who has the sophistication? It turns out in many countries the answer is the people who are the potential customers of a drug being peddled by an international drug company who is prepared to finance your litigation. But outside of that, there's a huge class and income differential in access. We see that in healthcare systems in low and middle income countries all around the world. Indeed, we see it in healthcare systems in upper income countries. Every study of access to healthcare by social class in the US, the UK, France, Germany, whatever, shows huge social class gradients in people's capacity to get to the right doctor, negotiate the right bureaucratic process, and so on. And this is certainly true of what we know about legal process. So I'm not persuaded that I'd say the principle, I think, is not helpful, and I'm not persuaded that it, in fact, is egalitarian in its operation. So I want to offer an alternative suggestion. I am very troubled by the extent to which cost-effectiveness analysis, as conventionally practiced, is not distributionally sensitive. Cost-benefit analysis says, in the application of Bentham's famous phrase, the greatest good for the greatest number, add up the gains to everybody and minimize the cost of producing those gains. There's no reason why we could not have distributionally sensitive cost-benefit analysis. There's no reason why we couldn't say, let's value gains to people who are worse off as more valuable than gains to people who are better off. So that when we do the analysis, a quality-adjusted life year added to someone who has a long and full life expectancy is less valuable than a quality-adjusted life year added to someone who can otherwise expect a shorter and more troublesome life. And we explicitly introduce a redistributive obligation in our decision-making. Also, as I said to Maria-Luisa, I'm very sensitive to the fact that evolutionarily human beings are very uncomfortable with cost-benefit analysis when they confront individuals who have no other alternative and are about to die. And quite a number of countries around the world have catastrophic care funds or crisis funds or exception funds. If those funds are transparently operated, they provide a way of meeting the care needs of people who are desperate at the same time in a budgetarily controllable way, exactly because the amount put in that fund is not justiciable against an essentially unlimited constitutional claim.
Thank you very much, and this is becoming very complicated for me, because remember that this is a country where I can only spend $36 per person a year. So, and this is a country where almost half of the expenditure comes from the pocket of poor people. So, and more than half of the population are poor. So, I certainly see the risks, but I want to hear also from Professor Mulley, what does he think, does this mean in terms of delivery of care?
Well, it is very complicated. I don't think there's a clear, simple path to either understanding what a constitutional right to health and therefore health care means, and its implication for policy and priority setting through cost-effectiveness analysis or other methods. I do think, though, that there's a great deal to learn from countries that have not stood strong for equity in healthcare, and those that have, in the way in which they've designed their political economies and held themselves accountable or not for delivery of care. It's pretty apparent if one studies, for instance, the United States and the United Kingdom, that we don't do a very good job of respecting people as individuals. We don't do a very good job of being sure that they are informed and engaged and supported in their preferences being constructed so that they can make choices that actually reveal preferences that contain in them enormously valuable information for decisions about how to design the delivery model and where to invest in capacity and where not to invest in capacity. I think many of you probably know the work done at my current institution, Dartmouth, where I've been for the past 3 years, that suggests that the more we spend on a per capita basis in the United States, threefold variations in the Medicare population, does not produce better outcomes. In fact, if anything, it's likely that outcomes are worse. What's going on there? And if we estimate that 40% of what we spend here in this country is waste, is that due to market failure and exploitation of market failure? Well, probably not, because in the UK, when you do the same kind of geographic variation analysis, you find that there are threefold variation in per capita costs of cancer care and heart disease care. And if you drill down and get into some of the details, you see major efforts to expand capacity, for instance, to treat heart disease with technology stents in the UK. In the U.S. or the UK, 80 to 90% of the people who have that procedure done believe that it reduces their risk of a heart attack, and it doesn't. Where's the respect there to engaging people in a participatory way in the design of their healthcare system? Now, what does this have to do with a country like Africa? Again, there are no easy answers here. But if, as you're beginning to think about the future of a delivery system design and the way in which one engages people individually and collectively, as articulated at Alma Ata on one of the occasions when a rights-based approach was articulated, how do you think about respect for the individual and the absolute need, if you do respect the individual, to engage them and understand what a particular service means to them, given their context. Think for a minute about the need to develop curative care services for a non-communicable disease or for cancer in a country like Africa. And one could argue that there is a moral imperative to reach for the ability to provide services that one knows could cure people who have early-stage cancer. If one makes that investment without paying attention to the alternative upstream investments that could be made that haven't been paid a lot of attention in the developed world, the curative care facilities built to cure cancer will end up largely being occupied. Those hospital beds will be occupied by people who are there because the cure didn't work and there's nowhere else for them to die in comfort. And you get onto this continuous cycle of investing downstream in the acute care facilities rather than upstream where things could make a difference. Let me just come back to one point. I'm going to argue that cost-effectiveness analysis, Mark, has the potential to fuel the kind of waste and harm that I'm talking about. Cost-effectiveness analysis necessarily, like much of the evidence-based approach to healthcare, rests on populations rather than utilities or risk attitudes or discount rates of individuals. So it's based on an average utility. How do you feel about this health state? And you ask a whole group of people and you use that average to do your cost-effectiveness analysis. And economists would also talk about risk attitudes and discount rates. And these priority-setting analyses being based on averages. Well, there's a wide distribution of how people feel about exactly the same health state and exactly the same risks. And in countries everywhere, without acknowledging that and thinking that the medical research that tells us what the probabilities of different outcomes are with different interventions suffices to make the treatment decisions without engaging the individual to see what their individual feelings are, ends up giving interventions to people who wouldn't choose them while you withhold the same interventions from people who would. Either directly when it's not a question of constrained resources, or over time because of how uninformed the capacity investment decisions have been made, because if the decisions made at the level of the individual aren't informed, the decisions made at the aggregate are uninformed. So let me stop there because I think there will be more opportunity to talk about this as the story progresses in Africa.
Thank you. Certainly. I mean, we'll go later into more into the what do I do now, because with all these answers, and how would I move forward in my country, in Africa. I want to hear then what does Professor Schmidt has to say from the bioethics point of view. What does it mean to have the right to health in the Constitution the way it's written?
Okay, thank you very much. I think I want to flag two things that I think are useful in this characterizations and two things that require a little more thought, again, before engaging with the comments of my colleagues that I think were also very helpful. So the first is that the mention of saying that the right to health includes the right to health care is, I think, a very useful one. And equally, it is useful to say that it talks about the state and every state organ, right? And the reason I'm saying is because I think it draws attention to the fact that there's a broad and a narrow conception of a right to health. Let me just put this into a little more context here. So some of you will have seen this cube that the WHO uses and effectively says, well, the right to health talks about who's covered. You know, if you look at the front of the cube, how many people are covered. Then you talk about what kind of services am I giving to these people, and up and down, what is the cost impact on the people who access this basket of service. So the question about the right to health often is characterized as what is the shape of the cube, and rightly so. But I think it's too narrow, right? And the reason it's too narrow is because healthcare is only one among a variety of determinants of health. So I'd suggest it's useful to take a broader view, and I think that is enshrined in Africa's constitution here. And this is also echoed in a report that many of you will know that Michael Mahmoud chaired for the WHO, taking a capabilities approach. And of course, they acknowledge that access and utilization of healthcare is vital to good and equitable health. But they went on to say, well, or rather, this is the Director General's quote here, to say the Commission's main finding is straightforward. The conditions in which people are born, live, and work are the single most important determinant of good health, of ill health, of a long or productive life, or short a miserable one. So the right to health in the narrow sense, in terms of what we get through healthcare, is one aspect of this, but we need to take a broader picture. And let me make it more concrete by giving an example of tobacco. So WHO estimated that in the 20th century, 100 million people died of tobacco. In the 21st century, in a 2008 report, it was estimated that 1 billion people will die from tobacco, and 80% of those people in developing countries, right? That is the total population of India around 2,000. That is a lot of people. It's a very quiet country. Right? If nothing happens, that is a worst-case scenario. So here you see some stats also that show you how both the production and the consumption of tobacco has increased drastically in developing countries. The conclusion that the WHO draws from this in this report is, well, what we need to do is empower people, so monitor tobacco use and prevention, protect people from tobacco smoke, offer help to quit, warn about the dangers of tobacco, enforce bans, and raise taxes, right? Now, that is a measure that, in my view, has very much to do with a right to health, but it's completely outside of the healthcare context. You could say, well, smoking is a right that we have as part of our good life, so we let people smoke, and then we deal with transplants maybe, and we've already heard the problems around this. Well, the opportunity cost if we provide transplants, what other things do we not provide? So here's a real case where both on ethical reasons we can prevent harm to people, and on cost constraints reasons we can make more efficient use of resources if we focus on the broader picture. And one other thing that needs is credible corporate social responsibility and a state that is willing to intervene when markets fail. So this too, I think, is part of a right to health agenda. Then I want to flag one other thing, which is in the quote it talked about the progressive realization of the right to health. And I think we've heard already the controversy around cost effectiveness analysis and those things. And I think this is an appeal to patience and flagging that this is a process that requires a number of inputs. So again, to put it into context, I would say we need to think about the dimension of the cube, yes, but also around broader public health efforts. And then we need to make these three kinds of prioritizations. One is, how much attention do you want to pay to the broad picture? How much to the narrow picture? Then, which dimension of the cube am I extending first? When we're talking about universal coverage, the idea is, of course, first that we extend it to everyone. But then, is it more important to provide a comprehensive benefit basket or to reduce the cost impact, right? That's a trade-off you have to make. And then within the package, and that's what we've already heard, apologies for this odd font here, there are a number of unsolved or probably unsolvable ethical problems, as we've also heard. There's the priority problem. How much priority should we be giving to the worse off? And we've heard Africa has a particular problem with unequal distributions. There's the aggregation problem. How should we count minor benefits to a large number of people versus large benefits to a small number of people? So all those things, reasonable people will disagree on. And here's one approach that Norm Daniels and Jim Sabin have set out that has a lot of currency in the debate, as many of you know. So they basically said, in the face of disagreement about the substantive principles that should guide the distribution of those resources, what can we do? Well, they propose this approach of accountability for reasonableness, where you make the justification of distribution public, as we've already heard emphasized, where you have irrelevance conditions that I'm going to go back to, where you provide the opportunity to revise policy if you think it turns out wrong, and most of all, you have clear regulation that you can challenge, which is part of the enforceability. So the relevance condition is met when a decision is reasonable in the sense that it appeals to evidence, reasons, and principles that are accepted as relevant by fair-minded people who are disposed to finding mutually justifiable terms of cooperation. And I think that's very important to what we've heard initially, too. The right to health doesn't mean that every person can say, I want everything. Every person has to understand, I live with a lot of other people here, and what I want affects what these people can get, right? So there's a contractual setup here that is very important in this. So that, I would say, in a slight defense of a right to health, which I think is a good occasion, but by itself, it won't settle a lot of the thorny issues that we have to deal with. And very briefly, two problems that I think with the definition. So one is, it says every person is entitled to the right to health. So what does that mean? Is it every person who happens to be in the country, every legal resident? Is it every citizen? Does it include prisoners or asylum seekers or migrants, right? That's another question that, especially in a resource-poor country, you'll want to think about. And then there is another dimension, which is that for many people, rights go hand in hand with responsibilities. So that's something I've, in a different context, thought about a little more. But, for example, in Germany, the law that governs the provision of health insurance, the very first article is called Personal Responsibility and Solidarity, right? So it means we're all in this together in some sense. You're entitled to claims, but in return, we expect that you do certain things. You look after your health, you don't use services unnecessarily, etc. So that is a question that can come particularly to the fore in a setting such as this, where there is a lot of pressure on making efficient use of resources. And I would just want to leave it at the point to say that responsibilities can be good and empowering, but they can also be very, very penalizing and unduly coercive. So that's another thing we might want to think about maybe later in the discussion, but that's where I'd leave it now. So I would see the enshrining of a right to health in the Constitution as a conversation maker, as a reason to get people to think about how that can be secured, and as something that can't be narrowly focused just on healthcare delivery.
Thank you very much. And I want to go back to what you say. You said at the beginning that health is not only the result of how good and how much health care we can get, but also, other factors like how people are born, how they live, and how they work. But yesterday I heard Justice Sachs said something like the role of the law is to transform misfortune into injustice. And if you are born with a genetic problem, or if you are poor, if you don't have the right work, you have a misfortune. And in his view, if I understood correctly, so everybody is open to correct me if I misunderstood, he said the role of the law is to transform misfortune into injustice, which I thought was very profound. Before we go into, you mentioned so many very interesting things, the concept of progressive, but I really don't know what to do because I have so many poor people. I have half of the women that cannot really get not even prenatal care. And I have, I'm trying to remember how many people live under $1.25 a day in my country. There are too many. And so I want to ask two questions in one for all of you, so to then open for a discussion with everybody here. And are the questions of what do I do and how to do it. Because yesterday I also received a communication from the president saying that we will have many more resources because the country has found a lot of richness on oil and other minerals. So the extractive industry is producing important revenues for the country. So that might help me in the thinking of how should I move towards universal health coverage. So who would like to go first? What should I do and how should I do it? Please, Mark.
So I think it's important to understand that the healthcare delivery systems in the public sector in many low and middle income countries are a disgrace. And it's not just my judgment. We can see that citizens believe they're a disgrace from the fact that they don't use them if they can possibly avoid it. And this is one of the, I think, under-discussed realities of trying to deliver services to people. If you go to places like India or Egypt, huge public infrastructures, often underutilized. And one of the interesting experiments around the world is the new Indian insurance policy that pays people that finances people's use of contractual partners, including in the private sector. So I think this is a very interesting question, Maria-Luisa, that you raise, which is if we are going to say, as I think we should, that we should prioritize people of low income and in underserved rural areas, and people with short life expectancies, and people with high incidence of maternal and infant mortality. If we're going to do that, the interesting question is how do we actually do that, and how do we get the political will on the part of you as the minister and the president and the prime minister above you to actually provide those services. And if you look at some of the places that have done this best, and here I think I agree with the point about process that our colleague from Colombia made. If you look at some of the places that have done the best on this, like Turkey, for example, they have done well because the governing party has decided that it's more important to rally democratic political support by providing services in poor areas than it is to hold on to the private revenue streams that corruption and patronage generate. And so they start running the public sector for the sake of the customers as opposed to for the sake of the political party and the government and the employees. And this happened in Turkey because of effective political competition, because the Justice and Development Party came in and has been seeking to try to maintain itself, particularly by getting support from the poor and rural areas when the urban elites were largely focused on traditional secularist and Kemalist ideology. So I think one of the answers to your question is I would like to see the allocation of resources be pro-poor, and I am interested in whether or not the political substrate is there in your country to make that happen.
Thank you. I do have support, and I do agree with you. So, but I still don't know how to do this without having everybody coming and asking for more.
Thank you. I would like to come back a little and to answer to Marc Roberts' assertion that to incorporate the right to health in the Constitution is useless or worse, dangerous.
I thought I would get us off of being too polite, right?
What I think is the paradox is that I agree a lot of what he's saying, but the presupposition of his analysis, but not the conclusion. The proposition is that you have to think really in rights in a resource-constrained world. I think there is this very good book of Stephen Holmes that sustains the cost of rights that show if you speak really of rights, if you take seriously rights, you have to take seriously resource constraints. I agree totally with that. And I agree that if the idea of enshrining in the Constitution a right to health is to establish a direct, judicially enforceable claim of any citizen of any kind of healthcare attention without resource constraint, is not only dangerous but stupid. But really, when you put in the Constitution a right, you never put an absolute right, except perhaps the right not to be tortured. But it's not becoming very absolute nowadays. But usually it's an absolute right. But all rights in a constitution are relative rights because they become in tension with other rights or public policy objectives. For instance, if you put in the Constitution the freedom of expression, as usually the Justice Holmes said, it doesn't mean that you have the right to shout in a public cinema fire without being a fire in the cinema. That doesn't cover that. So what I think is that the analysis of Professor Roberts is that the right of health implies this kind of claims, individual claims, that the judicial system should provide any kind of health care attention without resource constraint. And of course, if that's the idea, I wouldn't agree with this notion of the right to health in the Constitution. But I think that the incorporation of a right to health in the Constitution creates, and I agree very much with Harald's approach, a kind of conversation between legal arguments and other public policy arguments. And what I think is that Norman Daniels' approach to establish priorities in the health system is exactly a human rights approach. Is exactly what I think that the judicial system should make when the right to health is incorporated in the Constitution. That if they are going, if the political authorities are going to make some kind of priority setting, I can claim by judicial means that is making a transparent way that there is some kind of way to appeal to the decisions that are made. I'm not in favor of the possibility of making individualized claims, except in very specific cases. And I think that...
So you're against what's happened in Brazil and Costa Rica, where there have been such individual claims?
I'm against to some of these developments, not to all. I'm against the idea of judges that are not sensitive about the redistributive impact of their decisions. I'm against that. But I think that you can have some kind of enforceable claims in the courts, and this does not mean that always they have the consequences is this regressive impact of the judicial decision. We have made a research showing that some structural decisions, for instance, by the Constitutional Court in Colombia, are not at all regressive. They are redistributive, and they can be process-based, and that decisions that are process-based, taking into account the notion of the right to health in the Constitution and other rights, can improve really the way the health system works. But dispersed, individualized claims, I think they can create these incentives that is middle income or high income claimants, and usually, and in some cases with not very transparent relationship with pharmaceutical companies. I agree with that. But I think that this is not the consequences of the enshrinement of the right to health in the Constitution, but a bad interpretation of this incorporation by some courts. So, and coming back to your question, I would agree in the proposition of Professor Roberts in the way AFRIA should develop their policy. I think you can incorporate cross-cutting human rights principle, the issue of transparency, the issue of empowerment of the less favored sector of the population. We saw that according to the data, there are very high inequalities in the access to healthcare services, and this should be one of the focuses of public policy to remove these inequalities, not to provide the best health care for a small sector of population, but to remove this kind of inequalities. And I think that Harald is totally right that the notion of the right to health is not only the right to health care, but also the duty to the state, the duty of the state to intervene in the structural factors that has impact on the health of the population and try to make positive efforts in that area.
Thank you. So I think that I'm moving along a little bit, putting together the things that both of you have said. And so far, I understood, and correct if not, I should prioritize poor people and prioritize those with lower life expectancy or those that live in underserved areas. Look for the political support, which I already have, and allocate the money in a pro-poor way. And you said something quite interesting. You say, think of rights in a resource-constrained basis, so in a relatively to the resources that we have little, as you can see. But then you said to establish priorities is a human rights approach. And then you went into to establish priorities in a transparent way. So far I got a lot of things that I should do to move towards universal health coverage, given my circumstances. Let me hear what the others have to say to complete my picture.
So one thing looking at the data that I think is useful is to look, and this is looking at a particular area of action, right, is to look at the fertility rate, for example. So you have a fertility rate of 4.5 here, which is almost twice the WHO region average, and it seems useful to assess whether there is any unmet need for family planning. So there may be good reasons, of course, for having a lot of children, but it may also be simply a matter of lacking access to family planning or other barriers that are worth exploring. And that would be one way in which you can reduce quite drastically, if we're only looking at the health system side of things, the tension and pressure that you have on universal coverage by having a more manageable population. Otherwise, I think the key thing is to get the process right for determining what is the shape of the cube that we looked at and what should be the relationship to the broader public health measures. For me, I would say that cost-effectiveness analysis should be at the heart, both because it allows within condition category comparisons and across condition comparisons. It gives you a common denominator, a currency within which you can assess value for health gain. Having said that, it is perfectly clear that we need equity weights and fairness weights. And for that, we need to have a good process. And one thing that I think Dr. Mulley also mentioned earlier, and in fact, Dr. Roberts referred to when he said, well, oftentimes people vote with their feet and they just don't use services, is that we need to have some form of sense of what the population that we're trying to care for actually needs, right? We need to make sure these preferences are informed. So we want to be very clear about what forms of public engagement make sense. And I just want to show you some data of a study that I did with a colleague where we looked at why you might want to involve the public in health technology assessment and coverage decisions. And we only looked at 3 countries, the UK, Germany, and France. And the first thing to say is there's a wide range of different members of the public that are involved in these processes. Secondly, they're involved in very different functions, so as purely advisory or as co-decision maker. But one thing we found really striking, and this is data from interviews we did with very senior people at these respective organizations who run these processes in these 3 countries, was that there's a quite interesting disagreement about the rationales why you should do it in the first place. So you see here that, and 5 stars only means that this is very important, and 1 means it's not very important, that for the British committee, getting insight into new facts, and disease endpoints, what kind of preferences people have for conditions is the most important, not so important in the German system. to obtain insight into values such as should we really care for the people with the most severe diseases or the people who are most disadvantaged is almost equal but not the same. That this forms some part of legitimacy you see matters, but to a different extent vertically if you compare it to other factors. Then this can also be, of course, a way of ensuring that your decisions are acceptable, which can be distinct from a legitimacy rationale, and it can be a useful form of dissemination, of simply letting people know what the processes are that you have in place. So the main message I want to take away from this is that it seems necessary to involve the public in those decisions, but it's not really clear why, and it needs to be set out clearly why it is they engage the public in the first place, because otherwise you're going to have a lot of disappointed people if they're thinking, you told me you involved me in something, but actually I thought I was involved for this rationale and not for that one, so what's going on here? And one thing in which this can be done, and some of you may have seen this, is an interesting game, Choosing Health Plans Altogether, that Marion Danis and Susan Gould developed with others, which basically puts communities, and this has been tried in many regions in India in very successful ways, in the situation of having to put together a health plan for themselves first, and the way it's usually played is you then play it in a team, and then go back to do it yourself, and then decide a health plan for the whole community, where you basically have a set of tokens and you allocate them to these different interventions, and it is that activity serves various functions. So it can both help people reflect themselves what it is they want, as well as help policymakers understand what kind of needs situation do I have in my community. So since you asked what you should be doing, I think one other thing, aside from focusing centrally on cost effectiveness and thinking which equity and fairness weights you want to implement, is to involve the community, because you will have the most effective healthcare if it is accepted by the people that you seek to provide it to.
Thank you very much. Yes, so I will have to start thinking how I'm going to involve the community. Dr. Mulley.
If I were giving you advice at this point, I would say that you have to manage the present. You have to manage a situation in which we know that people don't have access to care that we know would be effective. And you need to work really hard at the progressive realization of creating those resources to allow people to have attended births, for instance. At the same time, given that there's the prospect that you will have resources to build the system and to expand capacity, I would argue that you should develop an innovation dedicated team, thinking about more transformational change, thinking about generational change for your healthcare system. And one way to do that is to say that the mental model of healthcare in most countries around the world is that highly trained people who have scientific background and technical skills are doing something to someone else. And that is the case in the operating room when people are anesthetized, or in the emergency room when they're incapacitated by illness or fear. But it's not the case in primary care and population health. It's not at all. I can say this because I edited a textbook on primary care. 60–70% of primary care is the bidirectional exchange of information about what your predicament means in your life and what possible treatments we might have for you. And the equally important information coming back to the service provider of what it is that you would value. And population health is even more of that, as you suggested with that last game. So if you recognize that the healthcare is delivered in complex adaptive systems that reside in political economies that are even larger complex adaptive systems, the biggest mistake you can make is overspecify what the different players should do, because you're going to have all of these end runs and all of the sabotage and all of the governance problems that relate to our need for more and more transparency in talking about that. The advice when you're dealing with a complex adaptive system is not to think like an engineer or an architect, not to overspecify, but go deeper and identify some simple rules that no one can argue with politically, but then find a way to measure whether or not people are complying with those simple rules. So I would argue, doctors are taught, we don't internalize and act on it as much as we should, but we're taught, first of all, do no harm. So I would argue that would be a good starting point, but then to argue that the goal of any health system is to give people the care they need and the care they want, no less and no more. And the no less and the no more are really important. and then say, this isn't just about highly trained people doing things to other people. It's developing the system to be sure that this bidirectional exchange of information that uncovers the needs and wants happens every time. Now, again, you can't do this in Africa for the whole country. It's too big, it's too daunting, but you could identify some opportunities at the interface between healthcare delivery and public health where you could really explore this mechanism. So for me, the simple rules are direction setting. This system, a generation from now or 2 generations from now, and God bless you if you as minister can think along those lines, this system is going to give people the care they need and no less and want and no more. And the boundary that we will never cross is to let decisions be made in the face of avoidable ignorance. And what we will most reward and carefully measure is demonstrated respect for the patient by engaging them, informing them, and helping them construct their preferences by recognizing their needs and wants. And we're going to do that in several areas. For instance, TB among minors in South Africa. And see what kind of impact that has on what has been viewed as an intractable problem for decades. I think what you would get is some pretty impressive proofs of concept. We're talking about hypotheses here to be tested. But 1 or 2 impressive proofs of concept along these lines could have profound effects on the way people think about investing in capacity. Again, going back to what I said before. If the decisions at the level of the individual are uninformed, the capacity investing decisions made at the policy level can only be uninformed. There is no Adam Smith's visible hand when you have asymmetry of information and disrespectful dealing with individuals, not informing them, not engaging them.
Thank you. So what you're telling me, if I understand correctly, is to plant the seed of something different. So I'm going to get some resources, and so I hope the president promised, so last night, so I will hold him accountable for that. But I also am concerned of going towards a system like ending up like the U.S., and sorry for all the Americans, or constructing more and more hospitals that are not really being used, as Professor Roberts was indicating. So, but at the same time, you're saying, well, we have to leave the present and we have to do something right now. And I have the Constitution and I have the Supreme Court and the Constitutional Court telling me, remember that we have in the Constitution that health is a right. So after this meeting, I have to go and tell them what will be the road to cross, so where to start and what to do. And I heard some very useful thoughts, and I definitely got from all this that I need to prioritize and also think that priorities are exercising human rights. And I also heard that trying to that don't be afraid of introducing some innovation and trying to understand what people really need and value, which I find difficult to, even if I involve the community in the right way and we go into the game of chat, what will people really value, and if what they value is what they will make them well. What if what they value the wrong thing? So how do I move them towards valuing what they need and valuing something that will make sense and that will make them well? So since I don't know, I open it for all of you to, if you want to give me more advice, and also to the audience, if you have questions and suggestions. First, let me just ask the panel if someone wants to say another word. Mark?
Well, first, I'm interested in the points of convergence among us. That is, I think there's a point of convergence among us about process. I think there's a point of convergence among us about the importance of redistribution. I think there's a point of convergence between Harald and me about when you start to talk about coverage, not to forget preventive public health measures, because in many cases, preventive public health measures are the best way to improve health status. And if you think the right is a right to health as opposed to a right to health care, then in some ways it's a great danger if you don't do the important preventive things like tobacco taxes and that you mentioned. I think that, and I think we also agree about both the value and the limits of trying to do a cost effectiveness. So I think there's quite a bit of agreement. The point where I agree with Al, although I'm not sure I understand everything that he said, it is clear that particularly as we move to chronic conditions, which is the case increasingly, even in poor countries, that in many ways the frontline healthcare worker is the patient themselves. And if we are, because it's the patient who has to take their meds, it's the patient who has to control their diet and exercise and so on. And I think that this notion about the centrality of the patient in the process is one of the important indicators of potential innovation. Because, and here I think Al and I agree, in many poor countries, the traditional model of delivery has been rooted in infectious disease, where you have a clinic and I show up and I see the next provider, whoever is there, and they give me an antibiotic and I leave. And for chronic conditions, both for screening and treatment, some ongoing continuing relationship between the provider and the patient and some continuity of care, I think, is essential in the design of the delivery system. And around the world, there are all kinds of different examples. The Brazilians use community health workers, and the Sri Lankans use maternity nurses, and the Germans use general practitioners, and the Turks have put in place family medicine doctors. The identity of the practitioner is culturally and resource constrained. But the notion of trying to create relationship-based systems of care, I think, is something you might think about, Minister.
I just want to respond to your question at the end about patients valuing something different than what you value. But before I do that, I'm going to acknowledge your reference to the U.S. And waste and harm here being 40%, and point out that there's no reason to believe that 40% or 20 to 40% is any lower across the range of wealth of nations. I mean, if you understand that the 40% waste reflects inadequate, ineffective, or harmful delivery of care that we know to be effective, but also represents overuse and underuse of care that we know is very sensitive to a patient's individual preferences. And we don't have time to talk about this, but this applies very much in the developing world as well as in the developed world. And then the third source of waste is generally overuse in the developed world, overuse and underuse of care that is exquisitely sensitive to supply. In healthcare, whatever capacity you invest in, whether it's human resource capacity or physical capacity, hospital beds, it will be used at any level, and that's a big part of why we're in so much trouble here in the U.S.
You know, that's just actually not true when it comes to hospital beds in many low and middle income countries where occupancy rates are 25%. So but if you think of it as a dynamic model, Mark, and I've had this conversation with ministers of health in countries with resources about the level of AFRIAs. If you think about it as a dynamic model, if you keep investing in the acute care facilities where the need is absolutely apparent, you know, these underweight infants are dying because there aren't enough bassinets in the neonatal intensive care unit, or people are dying because there isn't room in the emergency room.
that's apparent to you, and the response that all of us would have emotionally is we need more of those bassinets. But if you aren't at the same time investing in this knowledge-intensive service industry, primary care, population health, community health measures, you get on this treadmill and you keep building, and you end up with overcapacity on the acute side and continued undercapacity for the primary care and the population health, and where Harald and I agree. So the point I wanted to make is that I'm talking about kind of a big sky transformational set of experiments to do, but it's not just theoretical and impractical. I would hold the system accountable within those dedicated teams that are experimenting in some key areas like maternal and child health, or malaria treatment and prevention, or TB prevention and treatment. I would hold them accountable for demonstrating that those that we serve understand why we're asking them to do something, and that we understand the trade-offs that they're willing to make and not make. And my contention is that's the only way that we'll ever build healthcare systems that give people the care they need no less and want no more, because we adhere to this no decisions made in the face of avoidable ignorance, and what we most want to value and therefore need to measure is whether or not the person served has been respected by the system.
First, I agree totally with Mark summarizing these points of agreement, and I'm agreeing all 4 points. But I would make this kind of recommendation that I think are in human rights law, but are also sound policy. Not always human rights law is bad policy, as a lot of people think. And the first one is there is this notion developed by the Human Rights Committee on Economic Social Rights about the acceptability of healthcare facilities. What is the idea of the acceptability of healthcare facilities as one of the components of the right of health is that the healthcare facilities should accommodate to cultural diversity, to gender diversity, and then it must be acceptable for population. And maybe this point that Professor Roberts puts, that in some low and middle-income countries you have a lot of facilities that are not used, is because you are not building facilities that are acceptable for people. So I think that's a very important point. The second is that if you take seriously the notion of participation, then you have to empower people. And one way of empowering people is to provide them with some kind of enforceable judicial claims, not about priority setting made by judges, but, for instance, that you can use the judicial system in order to object to some kind of priorities made by the public authorities that you think are discriminatory. And then you can empower people, and this can build the necessary political will to really provide health care for all the population in equal terms. And third, I think there is, it's not the focus of this session, but it's a very important one in which the recognizing of the establishment of the right to health is very important, and is the issue about intellectual property and the problem of access to drugs. Because one of the issues is that I think that now there is a tension and even a contradiction in international law between the international law related with the right to health and the international law related to protection of intellectual property that makes sometimes medicine very difficult to access for poor countries. So what I would advise you is to contract, to hire a very skilled lawyer in order to challenge all these international intellectual property on grounds of human rights and specifically on the right to health. And I can offer you my services.
I'll be very brief because we're going to open it. My advice, I think, would be have lunch with your minister colleagues and talk to the minister who's in charge of taxes and the minister who runs the economics side of things, and tell them, look, I hear that you have these people from Nestle and from British American Tobacco, and they want to do business here. That's fine, but ask them, why is it that you agreed to one set of consumer protections in Europe and in the US, and why do you think you can sell cigarettes one by one here, give them free at concerts, etc.? What's with these double standards, right? So I think there is a lot here, and I think it's absolutely right to flag this rise in chronic conditions. That's a major double whammy for many developing countries who both have to deal with undernutrition in one part of the population and rising levels of obesity and chronic conditions at the same time. So you really want to be sure there that you can, as much as possible, rein in failing markets and make sure that corporate social responsibility isn't just a three-letter word, but something that means something.
Very good. I have a whole list of things that I need to do, but I want to hear also all the suggestions from the audience. And I saw several hands on the first row, so and I think you were raising your hand, then your second, third. There was someone in the back, fourth, and someone in the back. I don't know. Go ahead.
Okay, two very quick questions for Marc. First on rights, and the second one on process. On rights, do you see any scenario under which a constitutional right to health care would be useful? For example, a pre-Medicaid U.S., would a constitutional right would have served the country, at least from a governance perspective, saved us a lot of political discussion? Is there a cost-effective analysis that can be done there? So that's number one. Number two, are there any examples of good processes that have been able to minimize conflict of interest and institutional corruption?
Let me just take very quickly. I agree with our colleague that if a human rights clause in the Constitution is an occasion for conversation, right? What do we mean by this? How do we satisfy it? How do we set priorities? If it's seen as a question, not an answer, and the start of a conversation, not a way to stop a conversation, then I take that point. I am skeptical that a constitutional provision will substitute for underlying political developments. The problem with the United States is, in my view, a lack of political commitment to solidarity and equality. And as we've seen by the fact that the Supreme Court reached, I think, in a totally bizarre way to reject the requirement for Medicaid expansion, having something in or not in the Constitution, as my former teacher, the political scientist Richard Neustadt used to say, the Supreme Court reads the election returns. So I'm just not persuaded that there's a magic bullet to surmount a lack of political consensus in a society.
All right, let's just collect several questions. So, go ahead.
Thanks for the presentations. Very interesting discussion. I wanted to ask Rodrigo about one problem that we have here internally at the bank, where when these human rights discussions go on, economists particularly seem to be uncomfortable with the idea that this is a never-ending story, that human rights provide the possibility for people to claim more and more and more and more forever. So I wonder if there are good experiences in countries, in real countries, where using the concept of minimum content and using the concept of progressive realization, there has been settlement. And so we can provide that type of information to task team leaders that are willing to take over the topic of a human rights approach to their operations here at the bank. And a related question is if there have been interesting or successful experiences working with the private sector to try to avoid them contributing to more tension than helping the settlement to stabilize, I would say. Thank you.
Okay. Please.
Thank you to the panelists. We've already had a discussion which is very wide-ranging in the issues that have been raised, and so I apologize that I want to raise an additional issue that hasn't yet been discussed, and that is the how question, to come back to how we achieve these goals. And I don't mean in terms of models of priority setting or resource allocation, which so far have been talked about, but how you actually, there's great consensus, WHO, UN, in this room, that universal healthcare is what we should be achieving. But how do systems move from A to B in terms of the politics of this? And so I'm currently working in health policy issues in South Africa, and you will know that they are trying to move from a chaotic system which currently is backed by social rights, the rights to healthcare, does have a large public sector, universal healthcare, but I agree with Marc Roberts, it's a basket case of a system in some regions, not in everywhere, but in some regions. So the government are trying to move to a universal healthcare system. That involves winners and losers, different stakeholders, and a very entrenched private clinical stakeholding group, private healthcare industry, who are vehemently opposed to these reforms and have a lot of power in the system. So if we think about the how, we're not starting with a blank sheet of paper where we're designing systems. We're starting with the messy reality of politics. So if there's time, just a few minutes on actually the politics of policy making.
Thank you very much. Yeah, that will give us for the whole afternoon. I will pass on to that question, which is a very important one. How does this affect the political economy? There is another one there. Yes, please. And you also, sorry, I didn't mention to the others, you can say your name and your...
Thanks so much to the panelists for a very interesting discussion. I wanted to raise one issue which I thought wasn't addressed as much as it could have, outside perhaps of Rodrigo Uprimny's discussion of how courts actually work, and that is the political economy side of this whole question. There are over 120 countries now that have a constitutional right to health. There's litigation in a large number of them in Latin America, but also outside of Latin America. And we have a large number of studies from a number of authors looking at what actually happens. I think that's the key question. With due respect to John Rawls and Jeremy Bentham and Norm Daniels and Christopher Murray and all those people, I think this is a political economy question, whether or not to constitutionalize something. It's not really a question about moral rights. It's about political incentives. It reminds me of when I first came to the World Bank, people were very keen on decentralization because in theory it brings things closer to people. But when you look at what actually happens, there are a variety of ways in which those local preferences aren't translated upwards, and you need to actually look and see what's happening. So looking at all these studies, what are some of the things that we know? One, courts are very strategic. You don't see countries where courts are bankrupting the government out of health rights. Even in places where there's a lot of litigation, say Sao Paulo, it looks like about 5 to 10% of the health budget, is affected by courts. A lot of time courts affect things that aren't about provision. They're about public health. They're about regulation, about the horizontal relationship between clients and providers. There's many more different kinds of litigation than the archetypal litigation of give me more of something. Then finally, on the question of just distributive impact, Professor Roberts was saying that he suspects this is inequitable, but that's not what the research shows. I've done work with Dan Brinks at UT Austin, looking at all of the health cases we could find in South Africa and India, and found that in each of those countries, 80% of the likely beneficiaries were in the bottom 2 income quintiles. Even in a country with a much more individualized pattern like Brazil, you see knock-on effects to people who don't litigate themselves. The reason for this is that although there are barriers into court, there are mechanisms to generalize benefits. like the common law, like public interest litigation, like abstract constitutional review. So I think we learn a lot more by thinking of this as a political economy question, because that's really what the issue is.
Thank you to the panelists as well. My name is Leonardo Cubillos. I work in the team of WBI in Health. I want to ask Harald specifically. You raised a point that made up going to notice is the point of responsibilities. As a physician, I'm still grappling with the concept that under human rights, only the state can be held accountable. To some extent, I think physicians could be held accountable. But you were raising the point of duties of patients. So my question to you is, do you think other actors, including pharmaceutical industry, could be held accountable under human rights?
I wanted to say that the discussion was very interesting, but when the discussion got into questions of how resources should be allocated and whether they should be tilted towards those with the shortest life expectancy and so on, I found it less interesting than the place you started, which is what's the role of the courts and the constitutions in this regard. And I think when Judge Sachs was talking to us yesterday about the Treatment Action Campaign case and the Subramony case, he very usefully distinguished between a case where the court found the government was being completely unreasonable in withholding antiretrovirals, which were readily available and inexpensive, and a case where the government was being reasonable in withholding dialysis because they couldn't afford to put everybody in the country who needed it on dialysis. And for me, the question then is, if you've got an articulable standard that the medical profession or the provider has come up with, which is not in practice or on its face discriminatory, on gender, racial, or other grounds, then maybe the courts should stay out of it. But a constitutional right to health care, as in South Africa, is useful. A constitutional right to the highest attainable standard, which is not the South African standard, but what was proposed for Afria, is actually not helpful because, as I think Marc Roberts said, it doesn't give you any basis for decision. So in my judgment, the way Sachs outlined it yesterday was really quite a elegant description of the role of the courts versus the role of policy setters.
Okay, so we are going to start with these questions. We have like 10 minutes or less. But if you want to stay longer, we try it, no? So should we start from the last question? Should the courses stay in or out? Wants to?
Okay. I will try to take the three questions, Barum intervention and both of your questions. I think we are still learning. It's a difficult issue. The freedom of speech legal doctrine have been developing for centuries, at least in the United States, and it is still complex. So we know that there are difficult questions that haven't been addressed. But having said that, what I think for me is clear is at least these points. First, I think to put in the Constitution a right to health is a good thing. Not only because, for instance, for the debate about tobacco, if you don't have the right to health in the Constitution, then some people can argue that to establish, for instance, a ban on advertisement might be an infringement in the right to speech and the freedom of speech. And it can be a lot of arguments about that if the right is not in the Constitution. If the right is in the Constitution, you can say it's a question of balancing rights, that clearly you can restrict the right for advertisement. So even for allowing the government to do things, to have the right in the Constitution is a useful thing. The problem becomes complex when, if we put the right in the Constitution and we take rights seriously, that means that courts have a role. If court will not have a role, then don't put the right in the Constitution. It's a political question. But if you put the right in the Constitution, the courts must have a role. What should be the role of the courts? And I think that's a discussion that has philosophical strands, and I agree with Barum, empirical grounds. We have to see what courts have done in the world. We must make comparative analysis, and then we can see which are good practices and bad practices. And I think that there are lessons to be learned, and that has to do with this idea of a core content of a right and the progressive content. I think that in relation with the core content of the right, that should be established within the Constitution, then the courts might have an enforceable claim by citizens, because it's a thing that should be provided immediately or very quickly by the government. On the contrary, with the progressive components of the health care, for the right of health care, I think that the best comparative analysis show that here the approach of the court should be a more process approach, that is to control the reasonableness of governmental decisions, and not to trump the priorities that were that were established in the governmental process, unless there is a clear proof of that this is discriminatory or unreasonable. But I think that here the notion of the highest to achieve the highest standard of health is useful, because it puts some kind of pressure on the government to continue to do the work. So I don't think that it's for instance, in relation to regressive measures, that the government said, okay, I have to come back. If you don't have this notion that you have to go to achieve the highest attainable standard, then you would accept in legal terms any regressive measure as a possible measure. Whereas if you have this goal, then a regressive measure is suspect. It's not forbidden, but it would be what in constitutional law in the United States you would call a suspect category, that then the state has to show a more compelling interest to validate this kind of retrogression measures. So I think we are learning, but there has a lot that have been learned, and I think these are the conclusions that I would take from this comparative analysis.
Thank you.
I just want to say something briefly about South Africa, where I've been doing a lot of work over the last couple of years. And this goes to your point as well, and the point about the comparative political economy of courts. I think the nature of the claim in the Constitution and the nature of the role of the court in the political system, these are very important design details about any constitutional protection. And so I think that, as in almost every other area of health policy, the devil is in the details. And the actual political consequences will depend a great deal on the details. The South African situation is extremely complicated, as I'm sure you know, both because there's enormous internal tension within the ANC and the leadership of the different provinces. Under the South African Constitution, health is a provincial right, and many of the things that the minister would like to do, he can't do because of that constitutional claim, and there's almost certainly going to be litigation around that. South Africa has also been lucky because the NGOs that have been in the forefront of litigation around health rights in South Africa are extraordinarily sensible, and they are process and principle and consistency oriented. They have not been captured by the more crowd. I do accept your point that in some cases constitutional claims can be pro-poor. I'm just arguing that in some cases they cannot be pro-poor, that it really is a detailed issue. And I also want to suggest it is not necessary to have a right to health in the Constitution in order to give the courts a reasonableness review over administrative practice. In the U.S., we have something called the Administrative Procedures Act, which applies to all government decision-making and holds up standards of reasonableness and process, whether we're talking about environmental policy or FDA policy or Medicaid policy or Medicare policy or whatever. So I just don't want us to come away thinking that the only way we can have a court-based constraint on bureaucratic arbitrariness is to have a constitutional right to health. There are other kinds of constitutional and legislative provisions that would do the same thing.
On responsibility, briefly, Leonardo mentioned. So the main reason why I brought this up here is that because for many countries, talking about rights will be intricately linked to saying, in return, you have some responsibilities as a rights bearer to access a certain benefit package or healthcare system. And in this Constitution in particular, there was this particular emphasis on reproductive health and family planning, I think, where you could imagine a scenario where somebody might say, well, you have a right to all these things, but in return, we expect you to access a certain level of rights, for example, to use these services, right? Now, that, to me, would be a very bad way of linking rights and responsibilities here. A better way might be to say, we don't expect you to use certain family planning methods, but to think about using them, for example, right? So that could be another way in which you can say that is your responsibility, but you do it in a non-penalizing way. It's also relevant, especially for, as Marc Roberts mentioned earlier, the centrality of the patient in the process when it comes to chronic disease prevention. So if you think of Mexico that has high levels of obesity than the U.S., then they might look to the U.S. and say, well, interesting, here from next year, for example, employers can charge employees up to 30% more of the cost of coverage, so that's around $1,500 if they don't meet body mass index targets, right? So that is something that people think is okay to do as a way of holding people responsible for things in a healthcare system where we have limited resources and we can't meet everybody's needs. Now, in my view, again, that would be a very bad idea because you can only do that if you have fair opportunity of choice. And that, given what we know about the determinants of obesity in particular, doesn't work, and it brings us back to the responsibility of the corporate sector. So the main reason I wanted to talk about it was just to say that I think we can use responsibilities in a useful and meaningful way, in an empowering way that isn't penalizing, but there is great potential for it to be abused. You also asked about the question of shouldn't we be holding other people responsible or accountable, and I completely agree with that entirely. And in fact, oftentimes that needs to be where the focus needs to shift rather than holding individuals responsible.
Thank you. Anyone else from the panel? Yeah? All right. Well, I think I have all these points of convergence, and one thing that I take from here very clearly is that the process is very important, and I have to start thinking on a participatory and transparent process, on the way that I will establish priorities and allocate the resources, and also in a way to measure so I can hold, or others can hold me and my colleagues accountable for what we promise. So we don't have any of those things in our system. We don't have any way to promote for participation, or we don't have any good information systems that could provide the information to be also transparent. So I think there's a lot of work to do. So I invite all of you to think more and send me notes on what to do next. And thank you very much for participating and for being here. We don't have any more time. We could stay here for the whole afternoon, but they are telling me from the door like, hello, hello, we need to go. So thank you so much. Thanks a lot, everybody.